So I'm Major Richard Osei Boateng from 37 Military Hospital. I have the honor of presenting this topic, which was given to me a week ago. I must admit, I took a personal interest in this topic because we're currently doing some work in this area of HIV and AIDS, a postgraduate research student in the University of Ghana, and I have some of my partners here. I would like to take the opportunity to introduce Dr. Apia Ejikum, who is also a member of this consortium. We do a lot of work in advocacy for the youth and HIV/AIDS as well. So I have 20 minutes for us to go through scaling up integrated, people-centered approach within the framework of universal health coverage. I'll look briefly at universal health coverage, and then I introduce the concept of primary health care because I believe the two move hand in hand. We also look at people-centeredness in health systems. We'll look at a strategy for scaling up, look at a few strategic directions, and then I'll conclude and we will take questions, if any. So what is universal health coverage, if we are to look at it from that direction? You don't agree with me that good health is essential to sustain economic and social development and poverty reduction. A lot of work and advocacy has gone on to improve the health of populations around the world, to make sure that health reaches everybody, both urban and rural areas, men and women, adults and children alike. So the WHO provided this simple definition of UHC as ensuring that all people have access to needed health services. And I want us to take note of this one, including prevention, promotion, treatment, rehabilitation, and palliation. That is where the focus is and has been, and part of what we are going to discuss will mainly be based on that, how we can integrate these services to achieve the best indices we are talking about. Just like Chad came to give their figures, we will look at how we can help use some of these combinations to help improve. So we look at the universal health coverage cube. The idea is to extend coverage to the whole population, also extend services to people who are not yet receiving services, and at the same time reducing costs and reducing the pressure on the pockets of individuals. That is simply the framework or the concept of universal health coverage. So we take note of that. What are the objectives of universal health coverage? There should be equity in access. Everybody, no matter where you find yourself, no matter your background, should have equal access to health services wherever you are. And there should be quality. Quality is key in all of these things. One of the questions that keep coming up is, in providing universal access, how is quality affected? We'll see how we can relate some of these things to the HIV and AIDS services we are trying to bring to our people. People should also be protected against financial risk. In an attempt to bring people the good health they require, we should make sure they don't end up being poorer than they were before. And then services must also be readily available. We will feed and see how these objectives can be met through some of the strategies we will bring up. I'd like to talk briefly about primary health care and some key components of it that will also help our discussion. We would realize that in 1978, when the Alma Mater Declaration was done on primary health care, back then the focus was still on promotive, protective, preventive, creative, rehabilitative, and palliative. I believe we've come across these words before. So we see how universal coverage and primary health care sort of move hand in hand. However, primary health care was the first intervention that spoke about targeting individuals and families. And that is one of our goals today. How do we take health to the doorstep of the individual? How do we take health to the doorstep of families? How do we get these groups together, communities, in order to improve the indices that we are looking at. Systematically addressing the broader determinants of health. That is, we also not only be looking at those indicators we've already mentioned, but we are looking at the social, economic, environmental, as well as people's characteristics. We are trying to send health to the people. How well do we understand their culture? Is it plug and play? What works in San Francisco? Would the same system work in Accra if you bring it here? What works in Accra? If you take it to Chad, is it going to work? So we will try to look at some of those correlations and how we can use the characteristics and cultural background of people to affect some of these changes. It also talks about empowering individuals and families and communities to take charge of their health. And we believe that these things, when done, can help improve on some of these indices. So what are some of these people-centered approaches that we talk about? WHO has outlined a global strategy for this. People-centered and integrated health services is a call for fundamental paradigm shifts in the way health services are funded, managed, and delivered. So we are looking at a more inclusive system where if the individual has a hand in raising the funds that will promote their own health, then they are going to be key stakeholders or key players in helping meet the target. If the individual, the family, and the community are also key members of managing their own health, and they have collaborative efforts in helping to see how these indices are delivered, they are going to change a lot of things in a lot of ways. This is urgently needed as populations are living longer. Yes, of course, these days we have the dynamics changing. People are living longer, and so the burden, when it still remains on one side, becomes too heavy for one person to carry. There is therefore the need to open up, involve individuals, involve communities, involve members to be able to meet some of the complex interventions that has been proposed over the years. Also essential to better prepare for and respond to health emergency crisis through integrated services, as became evident during the Ebola virus disease outbreak. We all noticed the world's response to the Ebola outbreak. Immediately, UNMIA was formed, and people were drawn from all areas. It's because some of these systems were in place, and people had already devoted themselves to fight some of these emergencies. Accra was used as a logistics base for the UNMIA operation, and it is simply because we were ready to help and to deliver. We had volunteers coming from all over to help in the fight against Ebola, and that is what we are talking about here. How prepared is the individual? How prepared are the families? How prepared are the communities to take charge in improving the health outcomes in their various areas? All people must have access to health services that are provided in a way that responds to their preferences. So a story is once told where some people went into a village which had guinea worm infestation. How were they going to help these people? Was the solution simply going to be to build up a clinic, get health personnel in there to help fight this guinea worm? However, close interactions with the people, they realized that these people were taking water from the same source as animals. So they tried to tackle the problem from the source. They sat down with the community leaders and came to an agreement and provided about 5 boreholes for the community. And the problem of guinea worm infestation was solved. So including people in managing some of these situations goes a long way to help. They are coordinated around their needs and are saved effective, timely and efficient, and of an acceptable quality. It is said that the family is the best nurse. So if the focus of health can now change in trying to empower families to take charge of how to take care of their sick relatives when they go home. The aim is to reduce cost and burden, and also reduce the length of hospital stay to help improve the quality of life of individuals. People-centered health services is an approach to care that consciously adopts the perspectives of individuals, families, and communities, and sees them as participants as well as beneficiaries. I call this one stakeholder engagement. Before you can take that HIV and AIDS message to that community, to that individual, you would need to sit down with them and have that discussion. Let them understand what you are trying to sell to them. Find out their background and how they can also contribute in helping improve some of these indices. And that is what people-centered approaches is all about. It requires that people have the education and support they need to make decisions and participate in their own care. So we realize that empowering people to take crucial decisions in managing their health is also very, very critical in strategizing for health. So what are some of the strategies for scaling up? We've looked at something on universal health coverage and primary health care movement, and we've agreed that both of these functions work hand in hand. So in order to get the whole population covered, in order to get all services in there, we would need to look at, first of all, what parallel programs are running. How can we integrate some of these programs to achieve the best results that we can get? We also need to look at actions on non-communicable diseases and also more recent calls to strengthen national emergency and disaster management and the resilience of health systems. How resilient are some of these health systems that we have in place? For instance, in Ghana, we have the CHIP system, which is supposed to be the grassroots of care. How effective are our referral systems, for instance? How easily can a patient move from one level of care to the other? What contributions do they have to make in all of these things? Have we even thought about the reversal of it? Instead of taking, letting individuals move far away to access care, have we thought about bringing care to their doorstep? So instead of moving from the hinterlands into the big cities for your ARVs, have you thought about setting up community centers and putting individuals in charge? Have we thought about peer education and peer counseling? How best will it be for an individual who is living with HIV and AIDS to counsel another individual who is also living with HIV and AIDS? There is that understanding and there is that collaboration, and it goes a long way to affect the people's health. These are some of the strategies we can adopt to scale up. Addressing the social determinants of health, like we've already spoken about, the economics of it, the emotional aspect, mental health and all that, we would need to address all of that. But also on more recent calls, yes, we've already touched on that. So what are the strategic directions we are talking about? There are 5 strategic directions we are looking at here. Empowering and engaging people through providing opportunity, skills, and resources. The community is stuck poor. How do we resource them? How do we empower them to be able to be key players in determining their health outcomes? We can start by giving them basic skills that will enable them earn some income and also contribute to their health. I have always been an advocate for, yes, universal health coverage. It should be somewhat free for the poor, but how serious would they take it if they themselves are not contributing anything to the fund that takes care of their health? Once there's a structure that enables them to also contribute directly to meeting their health needs, then they are going to be key players and they are going to take all the indices very, very seriously. Another strategic direction is strengthening governance and accountability. You can have the most beautiful of plans. If there are no policies to back them, it's a problem. We need governmental support, not only in the area of funding, but also in the area of policy. So what is the government proposing? Have laws been created, for instance, to take care of people living with HIV and AIDS in the country? What is the level of governmental support? And how accountable are the systems that are taking care of HIV and AIDS patients? All these governance structures need to be looked at and looked at carefully. reorienting of the model of care so that efficient and effective healthcare services are purchased and provided through models of care that prioritize primary and community care services. Do we stick to the old system of care, which is in no way improving the indicators that we have? Or can we relook at these models of care and find a way of reorienting them so they can serve the people better? That is another way we can also look at. So during our panel discussions, these are some of the key things I would want us to look at. One of the things we need to take cognizance of is the fact that most of these strategies work hand in hand. So for instance, you can have all these great ideas. If you don't create an enabling environment for people to also come in and contribute, I'm sorry, all the great ideas may not really yield much. How do we adopt these strategies? The first way I think we can adopt these strategies is to get down to the people. We need to get close to the people. We need to talk to them and find out what their real needs are. ARVs are being sent every now and then, but the indicators are not working. Is it that people living with HIV come for their medication, but they are not able to take them, or the medications do not really get down to them? We will need to interact with these people and find out what their challenges are to be able to resolve that problem. Most of these strategies, if well done, you realize that funding in itself is about 10 to 15%. But once you make it people-centered and you find out what the challenges are and what is stopping it, and you try to remodel some of the way things are done, it's going to go a long way to affect these things. The strategy must not be cosmetic, but must be tailored towards the community and individuals. You want to provide service for a fisherman, you need to understand what the fisherman does and how you can bring up strategies to help him. If you go bring a strategy from Silicon Valley, which is used for helping high-tech personnel, it's not going to work in the third world. Using high-income country models to solve third world problems, they've never really worked. What we can do is to adopt some of these models and reshape them to suit the environment we are working in. And that's one of the critical things I would want us to look at as well. Also, finding ways of improving individual health by understanding what they do and making them understand what to do. It's also one key way of strategizing some of these things. So you would need to talk to the individual, first find out where he's coming from, his cultural background, what is accepted in the area, what is not accepted in the area. Most of the time we find cultural conflicts especially interrupting with most of the programs we put out. And people are not sensitive or do not pick these programs up simply because of that. Health promotion, health prevention, and education activities to resolve preventable conditions. Most of the situations we have, we can look at through health promotion and health prevention. I think this are the last. So in conclusion, in order to meet the objectives of UAC, individuals, families, and communities need to be key participants in making health decisions that directly affect them. That is what I call the broader stakeholder consultations, which are very key to the success of any public health intervention. Once you involve the people, you can go anywhere. Understanding the people is the first step in meeting their needs. It's also one take-home we need to take care of. Participation in decision-making process breeds a sense of ownership of interventions, and outcomes can improve. Thank you very much.